All right, so it's time to start, and welcome everyone. So it's the third talk this year of our seminars in telemedicine and e-health, here of the Master in Medical Informatics of the University of Porto. We're here and online, and today we don't have one guest but two, and I'll just present one because the host, my colleague, Dr. Ricardo Carvalho, Head of Cardiology of our Unidade Local de Saúde Gaia Espinho, and he graciously agreed to be the host of a very special talk today. And so, Ricardo, you're in charge.
So, good afternoon, everybody. Thank you very much for this invitation to Miguel Coimbra and all the team. It is a pleasure to be here in this idea of working multidisciplinarily between doctors, engineers. We have been collaborating in the last 2-3 years, I don't know, with, I would say, with some success. And I seriously believe that it is with this multidisciplinary view, bringing together clinicians with engineers, with all fields of knowledge, so that we can also improve the care to our patients and to think outside of the box sometimes, which what we will try to do today. So today we have a very special guest with us, okay? So probably you don't know him, because most people I know is from engineering and data science, etc. But we have a very special guest because we have here today with us in Porto, Professor Juan Atay. I don't know if you know him, but Professor Juan Atay is the chair, what we call Professor Catedrático, full professor in the University of Santiago Compostela, but he has been all across his career, he has been one of the most famous cardiologists, not only in Spain, but in Europe. He received several times the award of best doctor in Spain, a lot of new ways of thinking. Very important thing, this idea of having healthcare available to all society, which is very important. But he has been a pioneer and innovator in bringing the best care, cardiac care, but outside cardiology, to all patients, but also thinking a bit outside of the box, thinking on electronic records, a lot of new things that he has done for medicine, for cardiology, and he is a reference in Europe in cardiology. So we are very honored. He is also a very good friend. We have been collaborating in several initiatives with this team also, but with his team. And I'm sure he's also a fantastic communicator, but most importantly, he is a very good friend of our country, of our hospital, and it is really a great pleasure to have him here with us. So, one thing, take advantage. He will do a speech, but the most important thing, ask him difficult questions at the end. Try to think outside of the box because he's the perfect person to think outside of the box. So, great pleasure to have Professor Juan Atay with us today.
So, good afternoon, and first of all, I would like to thank Miguel Coimbra for the invitation to be here. As you can see, Ricardo is a close friend of mine, otherwise it's difficult to understand his presentation. So for me, it's a privilege to be here. I can start by saying that the chief of the cardiology department in Santiago is an engineer. It's an engineer, it's Margarita. For many years, more than 10 years, she takes care of the quality markers and organizing how to manage the management of the patient care pathway and how to measure quality markers with the aim of identify opportunities for improvement. So I will try to share with you some experiences in the cardiology field, but beyond the cardiology field, as Ricardo said, probably the most important part of this afternoon is the discussion. So I have no disclosure related with the presentation. And when you are talking about clinical management in cardiology, but clinical management in this case in medicine, you have to discuss several aspects. First, the health system where you are involved. As Ricardo said, we are involved in the public health system. The public health system in Spain is the most important social achievement. Nowadays continues to be a strong health system, particularly for the more heavy conditions, health conditions. So we have to discuss how is in this case, the public health system where you are included, where you are involved. And then you have to discuss the type of the patients you have to take care in this case. So you have to define the patient care pathways. First, in the ambulatory care, the consultations, for instance, or hospitalize the patients, how organize the patient pathway in different cardiology pathologies like heart failure or ischemic heart disease or so on, but most important, how organize how we improve the efficiency in the patient care in the ambulatory basis during the hospital stay, continuity of care, as in the title of my presentation, without integration, and particularly integration with ambulatory nurses and with the GPs, primary care physicians. They play a critical role because the cardiology diseases are chronic conditions, and without an integration with the GPs and with the ambulatory nurses, we fail, because during the hospital stay, you can take care of the acute conditions, but you have to guarantee the continuity of care. And then, for me, the most important thing, beyond define the patient care pathway, is you have to define quality markers. Which type of quality markers, quality indicators in the process, but quality indicators related with the outcomes or related for the efficiency, the cost. So, and I like to finish my presentation on the artificial intelligence, how apply artificial intelligence and digital transformation. Beyond artificial intelligence, I think it's more better to say digital transformation, in this case of the health system, public or private, but in my case, the public health system. Oops. There's not. Yeah, this is. Yeah. But on this slide, you can see the integration in a public health system where, as I said, the primary care plays a critical role in pathologies like cardiovascular pathologies, because they are highly prevalent pathologies and chronic conditions, and with a perspective of a concrete specialty like cardiology, it's impossible to organize the care of thousands of patients in a health area. You have to integrate the care, particularly with GPs and ambulatory nurses. And then the hospitalization, other issues related, in this case, the public system. And on this slide, you can see the importance of the GPs in chronic conditions. This was published several years ago in JAMA, and you see that the outcomes in cardiovascular disease and in oncology are critically depend not only by the number of the cardiologists of oncologists, but in the same way with the numbers of GPs. The GPs plays the same role in the outcomes like cardiologists or oncologists. So you need the integration, because if only oncologists or cardiologists are related with the outcomes, you can organize the pathology based on cardiology or oncology. But in this case, it's needed to integrate GPs, otherwise you can deliver an adequate care. This was published, I'm sorry because this is in Spanish, but it was recently published. This focus on this issue, the role of GPs in the outcomes, in this case, in the mortality, in the risk of hospitalizations in cardiology patients. You see that if the patient has the same GP the 2 years before when the patient is referred to a cardiology department and continues with the same GP 1 year after, you see that the outcomes is much more better than in the case the patients are changing the GP. So the continuity of care from a GP perspective is a critical element in the outcomes of the patient. So this has a lot of implication in the healthcare organization, and as I said, GPs plays a central role in pathologies like cardiovascular pathologies, with a highly prevalent in the population. And in this case, this is the Darcy, was the UK, the National Health Service suffered a number of problems during the last 2 decades, and this is a summary of the Darcy report, how to address the challenges in the public health system in UK. And this is the summary, and it's needed to, without health professionals, the health system doesn't work. It's needed the commitment and the engagement of the health professionals. So this is, for this report, the first priority, how to engage, how to increase the commitment of the health professionals, in this case with the public health system. There are a lot of other elements, but for me, one of the most important is how digital transformation in the health systems, in this case in the National Health Service in UK, is an important factor for improve the efficiency of the health system, particularly for doing the things that are needed to do in the patients and avoiding the things that without an increasing value in the care of the patient. This is the main component of digital transformation, how to improve the efficiency, in this case, of the public health system. So the two main issues related with improving, in this case, a public health system is engage the commitment of the health professionals with the patient care, and the other main issue is digital transformation that recently, that probably will be published early next year, the European Cardiovascular Health Plan. And in the European Cardiovascular Health Plan, there are two main priorities. One is try to reduce the inequalities across the European countries. There's huge differences across the European countries. And the second main objective is digital transformation, how digital transformation may improve the cardiovascular care in the European Union. This is the European Cardiovascular Health Plan, will be presented early, probably in March, will be approved by the European Parliament. And these six are the main components. First is try to reduce the inequalities. For example, the cardiovascular mortality here in Portugal is around, I think it's 30% of the total mortality. In Spain it's almost the same. But for example, in Bulgaria or in Romania, the cardiovascular mortality is higher than 70% of the total mortality. And for example, compared with my country, with Spain, the life expectancy is 10 years less in the East countries in Europe compared with the West countries. And when you die younger, mainly you die due to cardiovascular pathology. So this is the main objective, how to reduce the inequalities across the European countries. But the second most important is how digital transformation may improve prevention, may improve cardiovascular care. For example, if you suffer a myocardial infarction here, if you arrive to the hospital, your 30 days mortality is around 6%. But for example, in Lithuania, a report from the year 22, the 30 days mortality in patients that arrive to the hospital. Other thing is the patient who died before to arrive to the hospital, but the mortality is close to 20%, is around more than 3 times higher. So this is one of the first objectives, reduce the inequalities, but the second is digital transformation. In this issue, you have to organize the patient care. In this challenge is critical the role of the engineers, other professionals, not only direct health professionals, but particularly, for example, informatics, mathematics, but from my perspective, engineers plays a central role. And you have to organize how to take care of the more frequent chronic conditions. In this case, the three main conditions, the three main pathologies in cardiology is heart failure, ischemic heart disease, myocardial infarction, and chronic ischemic heart disease, and atrial fibrillation. You have to define which professionals are responsible for the early detection, from the follow-up, how to manage the acute conditions, how to include quality metrics for try to identify the opportunities for improvement. And this is critical, the role of professionals beyond nurses, of physicians. This is the reason why in many health systems are including other professionals like yours, mainly informatics, always engineers, and other professionals that may increase the efficiency of the health systems. And it's the reason why your professionals' profiles like yours is needed to organize the patient care, the patient journey, and how to measure the quality in the care of such patients. This is our three main patient journeys. As you see, heart failure, ischemic heart disease, and atrial fibrillation. Probably more than 70% of the patients that we care in cardiology are these three groups of patients: heart failure, ischemic heart disease, and atrial fibrillation. Obviously, other group of patients like valvular heart disease and other conditions, but these three main conditions is more than 70% of the care in our day practice. And you have to define how organize the role of the professionals, the role of the cardiologists, the role of the GPs, the role of other professionals. And our philosophical approach is cardiology plays a critical role in the diagnosis and in the acute decompensations of the patients. And then the continuity of care are mainly driven by the GPs. But you have to organize how to connect GPs with, in this case, hospital cardiologists. I will try to show you some experience in this challenge, how integrate the ambulatory care in the primary health centers and the departments in the hospitals. For example, again, this is in Spanish, sorry, is how to define, for example, the patient is hospitalized in the hospital. This is how to organize the discharge of the patient from the hospital, and then how organize the ambulatory trajectory. And in this ambulatory trajectory, as I said, the GPs plays the most important role, but you have to organize how the GPs are connected with the hospital doctors in case that GPs have some doubts about the patient condition and in the follow-up of the patient. And at the end, this is the main objective. The main objective is not only to know the evidence, how to diagnose, how to treat a patient. The most important is how to implement the science in the patients. Yeah, because many times the physicians were all talking about the guideline recommendations. In all the congresses, guideline recommendations, new guidelines, but at the end, this is not the most important thing. The most important thing is how the evidence is translated to the individual patients. And at the end, you have to measure at local level if your patients are treated and diagnosed according to the guideline recommendation. This is implementation science. And in the European Cardiovascular Plan is stress this concept. You have to work in implementation science, how to deliver the best medicine to the patient, because at the end, the medicines of the intervention don't work in the paper. Works if the patient receives such interventions and if the patient are compliant with, in this case, with the medications or with the other things. The second part is how organize the different, as I said, clinical situations. the ambulatory care, the patients outside the hospitals, the hospitalization, and the after, how to measuring the quality and how integrate other, for example, how digital transformation experience may improve the efficiency in cardiology. This is works with the previous Minister of Health in Spain, and we did this report of this survey that is the elapsed time from the GP request for a cardiology consultation and the elapsed time to cardiology visit, which is the delay in cardiology care after a GP referral. And as you can see, this is terrible because it was increased over the years, and this continues to be the same. After a GP request for cardiology consultation in one patient, the mean delay in Spain is more than 3 months. 3 months is the delay in cardiology. This is in cardiology. This could be an issue of the resources, the number of GPs, or the number of cardiologists, but the question is maybe also an issue related with the healthcare organization, and we are convinced that healthcare plays a critical role and improves the efficiency in ambulatory care. This was published recently by our group. This is in heart failure patients. When a GP sends a request to a cardiology department for referring a patient, if the elapsed time is higher than 8 days, the mortality increases. And if the delay is more than 1 month, 30 days, the risk of mortality is increased, is double. So, but this is in heart failure, that is a critical condition. This is related with mortality, but also we analyze the risk of going to emergency department, the hospitalization. So the delay in cardiology care after referral for RGP is a critical issue related with the patient outcomes. And we defined many years ago in Galicia. Galicia has the strongest electronic medical record, probably not only in Spain, but probably in Europe, because from more than 20 years in Galicia is not paper in the patient care. And this is an integrated electronic medical record. GPs, nurses, doctors in the hospitals, we have the same access to the patient information. All the patient information is in our electronic medical record. So we define a new patient care, ambulatory patient care. When a GP sends a request to our cardiology department, previously all the patients are appointed for a face-to-face consultation. But more than 10 years ago, the GP sent a request in the electronic medical record, and a cardiology responds to the request in less than 3 days and decide. You can solve the request from the GP because sometimes it's a doubt in the treatment, sometimes it's a doubt in the ECG and other things. Can be solved without a face-to-face consultation with the patient. And it's around 40% of the more than 7,000 patient request or GP's request in a year. Around 40% are solved without a face-to-face consultation. But in the case the cardiology decides that the patient needs a face-to-face consultation, all the patient needs to be seen in less than 15 days. But as you know, the patient condition, you can schedule the visit for the day after or 2 days after. That is, you decide, but always in less than 15 days. So around 40% are not visit in a face-to-face, but the other 60% are seen, but in less than 15 days. But the main question is this impact on the outcomes, because the question would be with changing the ambulatory care organization, you have to worsen the outcomes, because in this case, 40% are not seen in a face-to-face manner. But, well, this is our statistics, the number, but you see that in this year we solved the electronic consultation in less than 3 days. And this is the main publication. This was published in the Spanish Cardiology Journal. This is a good journal. And you see that when an electronic consultation was implanted, the delay in cardiology care was markedly reduced. We start the program with a delay around 3 months, was reduced progressively, but when we implant the electronic consultation, the delay was reduced. But most important, you see that in this case, the hospital admissions was reduced, and the mortality was markedly reduced and then was stabilized. The reason why was you are able to identify the more critical patients, and you see the patient much early. Otherwise, the patient are waiting 3 months for a cardiology consultation. Most of the patients can need an emergency visit, can need a hospitalization. The mortality is increased, and with this change is based on electronic medical record. It's based on digital transformation. This improves a lot the outcomes, and currently this ambulatory care organization management was implanted in almost all the autonomous regions in Spain and was included as a best practice in the European Cardiovascular Health Plan. For me, this was the most important achievement with this new ambulatory care organization. This is our health area in Santiago de Compostela. This is around half a million inhabitants. And you see, when all the patients are referred for a face-to-face consultation, the rate of referrals was higher by the GPs closer to the hospital. The GPs in a health centers with less than 15 kilometers away from the hospital, we received the highest referrals. The patients living far away, more than 50, 60 kilometers, the referrals were markedly lower than the patient living closer to the hospital. But when we implant the electronic medical record, the access of the patient was irrespective where they live. As you see, the referrals was exactly the same in the patients living closer to the hospital or far away from the hospital. This was published in Circulation. This is a very good journal in the cardiology field. And with this digital transformation ambulatory care, you increase the accessibility to cardiology care, in this case in a region or in an area like Galicia, and in this case Santiago de Compostela, that is a rural area with very few big cities, but with a small group of patients living far away and isolated and far away from the hospital. So this new ambulatory care organization not only improved the outcomes, but also improve the accessibility of the more vulnerable people, the older people, the people living far away from the hospital. And now we are implanted a new model that is advanced e-consultation. Was published 2 days ago in the European Heart Journal, in a sister journal of the European Heart Journal, in the European Prevention Journal. And you see that which is advanced e-consultation. We train GPs in echocardiography, in echoscopy, in simple echo, and we train the GPs in continuous ECG recording, that is Holter, and these two main techniques in cardiology. And with this, GPs working with these two technologies, with echoscopy and with Holter, the number of solving the request by the GP without the need of a referral to our cardiology department increased a lot. More than 60% of the possible referrals in the past now are solved by the GPs using these two technologies in the primary care center. So again, digital transformation and increasing the availability of the cardiology technologies like echo and Holter in the primary care centers may improve a lot the efficiency of the ambulatory care. So hospitalization, how to may improve the patient journey during the hospital stay. And first, we try to avoid hospitalizations, classical hospitalizations admitted to the hospital, because hospitalizations is a problem with the patients. Many patients suffer complications during the hospital stay, for example, infections, falls. There are many complications. We have to avoid the classical hospitalization, and this is the reason why you increase the number of day hospitalization without overnight state of the patient. And we implement a day hospital, and we attend most of the procedures, for example, catheter ablations in arrhythmias, and diagnostic techniques in ischemic heart disease, like angioplasty in chronic patients, or for example, in heart failure, some procedures and treatments in heart failure. With the implementation of this day hospital, we reduce a lot of the number of the hospitalization, the classic hospitalization, and it's very safe. So it's needed to implement day hospitals in the cardiology field, but not only in the cardiology, but also in other disciplines like oncology and other disciplines, because it's highly efficient, it's very safe for the patients, and you avoid the classic hospitalization. You improve the availability of the number of beds in the hospitals. But in many patients, it's needed a hospital admission, a classical hospital admission with overnight, at least one overnight or more than 2 days in the hospital. This is our flow of the patient. In cardiology, many of the patients are acute patients, acute myocardial infarction, descompensations for heart failure, arrhythmias. Most of the admissions in the hospital in the cardiology departments are the acute conditions of the patients. This is our flow of the patient. We include different quality markers. On this slide, you see the different quality markers, because it's the way you can assess the quality of the care you are delivering to our patients. For example, this for me is one of the best quality markers during the hospitalization of the patients. That is the elapsed time, the delay, when the patients are attended in the emergency department, and a physician in the emergency department of a cardiology decide that the patient needs a hospital admission. The delay from this decision to the patients arrive to the bed in the ward or in the acute care unit. And currently, our delay is less than 2 hours. It's around 2 hours. And because if the patient remains in the emergency department, it's difficult to manage the patients. And for me, this is the most important, one of the most important quality indicators of the quality you are delivering the hospital admissions. This is not measuring in many reports of the quality of the hospitalizations of the patients, but because if the patients are admitted early, probably are stabilized much better. The treatment is more easy to be optimized, but we're measuring all the different quality indicators that you can see on the slide. But this, for me, is one of the most important. We obviously see the mortality. This is the mortality in myocardial infarction. We review the mortality every 2 months, and in this is it's critical the role of Margarita, our engineer, in measuring. And for example, this was presented by the Spanish Society of Cardiology. You can see in red to the right-hand side of the slide, in red is the mortality, the 30 days mortality of STEMI, of myocardial infarction, in hospitals that are more or less the same, because it's hospitals with intervention cardiology, with electrophysiology, with cardiac surgery, and you see that there are huge differences. The excellence cardiac departments, the mortality is much lower than suboptimal cardiology departments with the same facilities, with intervention cardiology, with the same facilities. This information is sent to the director of the cardiology departments. It's not possible to publish in a public domain, but it's sent, and we do some kind of benchmark. You receive your data and is compared with other hospitals similar to yours, but you don't know the numbers of the other hospitals, but you receive where you are. And I will say this is, for me, the best thing I did when I've been president of the Spanish Society of Cardiology. It's around 10 years ago. The mortality of myocardial infarction varies a lot among different autonomous regions, a lot. More than 50% higher mortality, for example, in Valencia than in Navarra. Which is the reason why? The reason why is the autonomous regions with an infarct code, it is a clear care organization of the patient with an acute myocardial infarction, have the lowest mortality compared with the other autonomous regions. After the publication in the two main Spanish journals, in Del País y ABC, the 8 autonomous regions without an infarct code in less than 1 year implement an infarct code. So this is the reason why the scientific societies have a high responsibility. Not only have to be clubs of health professionals, cardiologists doing congresses, meetings, wherever, that is important, but also the responsibilities have to improve the care of the citizens, in this case the patients with myocardial infarction, and sometimes it's needed to translate this information to the public domain because the politicians is the best way to respond, in this case, to this. In our country, after this was terrible because it was not very well accepted by many politicians at that age, but after this, in less than 1 year, 8 autonomous regions without an infarct code implement an infarct code, and this is, well, for me, was the most important thing that we did during our presidency in the Spanish Cardiology Journal. Yeah, this is quality indicators. Is needed to audit the quality. We are submitted to an audit process with the ISO regulation and several regulations, and this is not, you need to measure in your quality markers, but also you need some audit, external audit of your results. This is our external audit, and also, for example, in the research, because we are included in a university system, in a university hospital, we have the responsibility to increase the knowledge, to do clinical research, basic research, and in Santiago, for the last 3 years, we're the #1 in the cardiology network, cardiovascular research network in Spain. And this is the quality markers. You have to design which quality markers you have to measure. Probably we discussed in heart failure which quality markers is needed to measure in ischemic heart disease, but this is an editorial of the Spanish Cardiology Journal where we define our suggested 101 quality markers in cardiology. This is but this is our quality markers, but sometimes are changing. Some of them are excluded, some other are included, but you have to define at the local level your quality markers, how to measuring, and discuss, if it is possible, do some benchmark probably with the better centers, we are able to do some benchmark because we have the same quality markers from the Karolinska Hospital in Stockholm, and we have compared our quality markers with the Karolinska quality markers, and you see the opportunities for improvement. Because if you don't measure, you can know where you are. Measuring, you can know where you are, and can you identify the opportunities for improvement. And I would like to finish my talk talking about artificial intelligence, in this case in medicine and in cardiology. Artificial intelligence is prime time, is using in the hospitals, mainly used when you are is available an electronic medical record, because it's the best way to implement electronic medical artificial intelligence tools in the artificial intelligence tool in the decision-making process, for example. Artificial intelligence is not the future, is right now reality in medicine. And this is included. This is a very important table included in the European Cardiovascular Plan. This is how you currently deliver the care, but this is, we define how the future in the health system needs to be a transition for the classical management in medicine to a more efficient using digital transformation. For example, this was recently published in Lancet, Digital Health in Lancet. This is from a group of hospitals in Spain. We are included in the group, but this is led by Belvitge Hospital in Barcelona, and using electronic medical record with an implication of the nurses in heart failure patients recently discharged from the hospital, compared with usual care, you see the huge differences. It's terrible. This, if you include particularly nurses in the early follow-up of patients, heart failure patients discharged from the hospital, and you use some digital tools like a connection of the patient home facilities with electronic medical record, you see the impact. It's a tremendous impact in the outcomes, particularly in reducing the risk of recurrent hospital admissions. We are including voice recorder. Probably you know there are some artificial intelligence tools using patient voice recorder, and with this tool, you are able to identify the patient with a high risk for hospitalization, the risk of hospitalization, and we are using an algorithm recording the patient voice with a simple paragraph, and the tool is very effective in identifying the risky patients. And we are trying to include this in the electronic medical record in Galicia. And this is our algorithm that we developed with two engineer centers, informatics centers in Galicia, one in the University of Santiago and the other in the University of La Coruña. We use more than 80,000 consultations to our department. And we develop an artificial intelligence algorithm that are very strong. The performance in identify the risky patients is without an intervention of a cardiologist or of a physician. And you see in red that the algorithm is very efficient in identify the risky patient. And also we are trying to implement this algorithm in the electronic medical record, because in this case, it's not needed that a cardiology review the GP request. The GP requests are analyzed or is analyzed by this algorithm, and this algorithm identifies the risky patients that need to be earlier than other patients. And a lot of algorithms, artificial intelligence algorithms, for example, using the ECG, the electrocardiogram, in patients with chest pain. This was published recently with a single ECG in patients with chest pain. The algorithm is very efficient, is most efficient than a cardiologist in identifying the patients with an acute coronary syndrome. This is really impressive. And also in heart failure, with a single ECG in patients with a heart failure diagnosis, is very efficient in identifying the risky patients, and also with echo. The echo, there are transdermal pads, there are a lot of tools for doing the echocardiogram. That is a key technique in cardiology. The artificial intelligence are a lot of algorithms doing the exams, doing the report of the echo, and this report, the performance is at least similar to well-trained cardiologists. And for example, this is an example what we did in our electronic medical record using an algorithm that not only suggests a diagnosis but also suggests a medical treatment. In this case, the algorithm report is the patient may have heart failure with preserved ejection fraction, and also suggests you the use of an SGLT2 inhibitor, that is the current therapy in this case. So this is the sentence, the key message in this case. Artificial intelligence will not replace cardiology, but cardiologists who don't use artificial intelligence may be replaced. This is critical, and in this case, you play a role in this issue. So I like to finish by saying that is needed an integrated medical approach in cardiology, but not only with cardiologists, with GPs, but also some kind of how to organize the patient journey. But most important, you need to include digital transformation, particularly in the public health systems, because we need to increase the efficiency of the public health system, because the public health system, all the citizens, irrespective to the economic level, irrespective where they live, needs to be attended in well attended for the diagnosis, for the treatment, and we have to try to improve the efficiency of the public health systems. So I finish by saying that we have to integrate not only health professionals, but also other professionals. I start my talk by saying that Margarita, as an engineer, is the key person in our department. Probably most of you or all of you also can be included by being involved in the health system, and probably with your work, the efficiency of the public health system and the private health system may increase. So thank you for the
Stop the recordings and